Hi, friends. I hope some of you have had the chance to see and listen to my past five iterations and reminiscences of certain paradigm shifts which I have been privy and witness to since I began my career as an intensivist 20 years ago. I'm sure some of you would have identified some more paradigms which I have missed, but I think that's the experience we all get by working for long years in the intensive care unit. We have spoken about fluids, we have looked at ARDS, we have looked at SEPS, we have looked at AKI, we have looked at nutrition, so many aspects of intensive care. But the integral part of intensive care, which probably has also seen some paradigm shifts, is hemodynamic monitoring. And this is one area where our country has actually contributed to certain new and innovative methods of measuring or identifying the dynamic indices of wall fluid responsiveness. Way back in 2000, 2002, when I was trying to find my feet in this field of intensive care, Emmanuel Rivers actually came out with his seminal paper which spoke about certain methodological aspects and putting some kind of process and some kind of algorithm into resuscitation of patients in the emergency rooms of developing countries. And it included central venous pressure, but it also included some interesting parameters like SCVO2 and hematocrit. And they tried to put that into an algorithm and said that if you have a number of SCVO2 in this range, these are the interventions you should be doing. This is the hematocrit you should be trying to maintain. And it also put a method into the whole process of fluid resuscitation in emergency rooms. This impactful publication from Rivers actually was so effective and so influential that these recommendations actually made their way into the first or few guidelines of the Surviving Sepsis campaign. And we all practiced it for quite a long time, maybe as long as 2007, 2008, we were practicing some of the recommendations of the Rivers paper. Since then, except for the mean arterial pressure and to some extent the SCVO2, most of these recommendations have waned off as prime entities for hemodynamic optimization and hemodynamic correction among sick patients who come into the emergency room and from there into the intensive care unit. The CVP has been probably the most enigmatic of all these paradigms, of all these parameters. There were believers long before, and probably there are still believers in CVP as a hemodynamic tool because it's the most easily available, most commonly used, and most readily replicable, and probably the least invasive of all the tools we have at our disposal. So, we began to understand that assessing somebody's volume status based on a low CVP may be erroneous. And we also understood that those patients who are fluid responsive may actually have a normal CVP, and deserving patients may actually be omitted from getting fluids based on the CVP. Oh, from there, the CVP has evolved and emerged in a way that now it is considered that probably a high CVP is suggestive of a volume overload and it is time to de-resuscitate out patients. It may be true. And several surrogates of this, like the IVC diameter, the hepatic vein Doppler flow, the portal vein Doppler signals, the renal pulsatility, all these signs of volume excess have become normal parameters which we now assess as volume indicators of volume excess. So the CVP probably was the first such paradigm which emerged and gave us some understanding of how we should be measuring the response or the requirement of fluid. But as it waned off, it gave us some interesting answers and alternatives. The SCVO2, in my perspective, is a fantastic physiological concept which probably has not stood the scrutiny of meticulous scientific research. We all know that uncoupling of the electron transport chain at the peripheral level can result in poor offloading of the oxygen on the circulating blood, and that translates into very high SCVO2 values. So, while a low SCVO2 may not always be an indicator of fluid requirement or hemodynamic suboptimal homeostasis, a very high SCVO2 should probably ring alarm bells amongst the intensivists. Now, especially since two important molecules, the methylene blue and hydroxycobalamin, are coming back as interventions for hemodynamic optimization, the assessment of SCVO2 and a high SCVO2 as a marker of very severe disruption of the tissue oxygen delivery may be in the offing, and that itself will be a paradigm shift. Way back in the mid 90s and probably in the early part of the 2001, dopamine was still being used in some ICUs despite the ANZIC's paper, which recommended that it should not be used as a inotrope in the intensive care unit. In 2002 and 2004, when I was training in critical care, the unit where I trained actually did not use dopamine. One of the first units not to use dopamine for hemodynamic optimization, and several explanations were put forward, and we found that it is arrhythmogenic, it is immunomodulatory, it does not improve kidney function, and it probably increases the myocardial oxygen demand. So dopamine waned off from its prime position as an inotrope in intensive care units. And then slowly people began to accept that norepinephrine is the drug of choice for vasodilatory shock initially, and subsequently for nearly every kind of shock except for probably obstructive shock. But vasopressin, norepinephrine alone was not giving the results, and somewhere along the line you got the VAST study which showed that vasopressin could be an additive working through a different mechanism which could help patients reach their hemodynamic targets earlier with combined with vasopressin. Again, the use of vasopressin had its proponents and its opponents. There were people who believed that it triggers mesenteric ischemia, it can trigger myocardial ischemia, and it can cause several other complications. But subsequent studies, although did not show as much mortality benefit as the earlier interventions, vasopressin was not shown to be a harmful agent, and it came to be an integral part of the armamentarium of drugs which we use to optimize hemodynamics among patients with sepsis or most kinds of shock. For a long time, maybe from 2007 or 8 till 2018, these two were the only drugs which were available for hemodynamic support in terms of vasopressors, until you had terlipressin being tried and with mixed results. But the most path-breaking paradigm that shifted is the use of angiotensin 2. And angiotensin again has a different mechanism of action, and you can easily identify those patients who probably will benefit from angiotensin by looking at the renin activity. So this paradigm is probably now you have a sympathetic system targeted norepinephrine, you have the aquaporin targeted vasopressin, and then you have the renin angiotensin targeted angiotensin 2. So this paradigm of hitting the hemodynamic axis from multiple angles seems to be a very interesting and probably effective paradigm shift that I have witnessed in the last 20 years. We still don't have angiotensin in India, but it's only probably a matter of time before it reaches our shores. Somewhere along the line, when the CVP started waning off and other parameters were not actually, and the pulmonary artery catheter also lost its place on the shelves of intensive care, two important dynamic indices made their appearance in intensive care units. And again, the unit where I trained in Bangalore was one of the first to use stroke volume variation and pulse pressure variation. These were very elegant and scientifically robust methods of assessing volume responsiveness using heart-lung interactions. But we all know that this probably were applicable only to a small percentage or maybe a one third of your patients who come into the intensive care unit because of the issues of not being effective when there is a spontaneous breathing, not being effective when there is a rhythm disturbance, and not being validated for tidal volumes less than 10 mils per kilogram of ideal body weight. And as I spoke about ARDS, the 6 to 8 mils per kilogram ideal body weight tidal volume began to be applied not only for ARDS patients but for all ventilated patients in the intensive care unit, including the perioperative and immediate post-operative patients. So does the flow track, the so-called flow track, which looks at stroke volume variation, work when you have 6 ml or 8 ml tidal volume? And now are the days where we are giving ultra low tidal volumes to some of our patients. So will it really work? That was always the concern. So it was not applicable to the whole spectrum of hemodynamically unstable patients in the intensive care unit. And here we must appreciate that an answer was found by our Indian researchers who said that you can use a tidal volume challenge within the range described or prescribed by the ArtsNet group, but yet demonstrate responsiveness or the fluid responsiveness by looking at the tidal volume challenge test. So this has been a very exciting and rather a very important paradigm for me, that you looked at stroke volume variation, you looked at heart-lung interactions, but you actually extrapolated the tidal volumes and manipulated the ventilator and brought heart-lung interactions into hemodynamic optimization to the bedside, which can be applied across the board, whether you're in a tier 3 or a tier 2 or a tier 1 city, in a teaching hospital or in a private healthcare facility. So it is not an exclusive and inexpensive because the patient is on the machine anyway. So this paradigm of trying to bring the hemodynamic monitoring to the grassroots is probably has been a good paradigm shift for us. Another interesting paradigm that emerged and became well accepted, although its interpretation and its practice is up for debate, is the passive leg raising test. We were always concerned by giving fluids and fluid challenges that you could be actually tipping patients over into heart failure, especially in the context of low hemoglobin, which most of our patients come into the hospital with. So the passive leg raising test, if performed as it is described and has been recommended, of course combined with some kind of stroke volume monitoring, is probably an important paradigm that emerged in the last 10 years, which also is a less expensive and easily applicable and easily learned technique where you can identify those patients who are responsive or who are in need for fluids. The emergence of the passive leg raising test, as in my view, has been a good paradigm shift, as good as the tidal volume challenge. Now, the whole focus of hemodynamic monitoring and assessment has been to identify those patients who are in need of fluid. But the paradigm that has shifted and that has gone more importance in intensive care, and intensivists are learning the skills to test for, is identifying positive fluid balance. Yes, a meticulous chart review will always tell you if the patient is in a positive fluid balance. Whether this positive fluid balance is actually impacting the patient's hemodynamics can be done by now different methods of point of care ultrasound. This itself, the emergence of point of care ultrasound itself, is a major paradigm shift, and we will leave it for another day to discuss how POCUS has influenced intensive care. But as far as hemodynamics are concerned, while we were looking at the left ventricular ejection fraction, left ventricular end diastolic volume, and the velocity time integral across the aortic valve in the initial stages of hemodynamic monitoring, subsequently we have learned to look at the venous system as well. We routinely started looking at the IVC diameter, its variability, the superior vena cava compressibility and distensibility. And we tried to extrapolate that and say that if this is the number, this is the percentage of variation, this is my possibility that my patient will be fluid responsive. From a uni-focused approach of identifying a full IVC versus a collapsing IVC, we have now gone to quantify the extent of fluid overload by the VEXAS protocol. We are looking at the hepatic vein, we are looking at the portal vein, and we are looking at the renal veins, and then with definitive Doppler patterns, and able to tell that these patients, the degree of fluid overload, and quantify them and grade them in in a replicable manner, so that if you have initiated a process or a treatment for the decongestion of the patients, you can actually do it serially, and you can and quantify how effective your offloading of fluid of this patient has been. So just from looking at ejection fraction and the filling pattern of the ventricle to the point of a quantifying assessment with ultrasound has been a good paradigm shift. While we are on that topic, the focus among intensivists has also changed from looking only at the left ventricle from a hemodynamic point perspective, from change to learning the techniques and learning the importance of the right ventricle as well as an important player in the whole cycle or in the whole game of hemodynamic optimization. The tricuspid annular plane systolic excursion, for example, has crossed the boundaries of only pulmonary thromboembolism and has crept into assessment of RV dysfunction among patients who have hypoxemic respiratory failure, who have ARDS, who are on higher PEEPs, and who are given a lot of fluids for resuscitation. So the emergence of sonographic assessment, including the lung ultrasound, to tell you which patient has actually accumulated more fluid and which patient probably can take in more fluid, has been probably one of the major paradigm shifts in my perspective. And of course, the importance which we are now giving to the right ventricle when you are assessing somebody's hemodynamics has been probably the most physiologically relevant and often ignored paradigm which has shifted in the last 20 years. A simple bedside test which can tell us that your perfusion is getting better or your perfusion is not getting better has emerged after the Andromeda shock trial validated the use of the capillary refill time. Of course, the method that was described in the trial is a very specific method of doing it, but if you can do it at the bedside, the capillary refill time has been shown or has been proven to be comparable to lactate and its clearance. A reduction in the capillary refill time has been shown to be equivalent to a lactate clearance when you are optimizing patients with hemodynamics with fluids and vasopressor therapy. So in the end, I think while we looked at CVP, we looked at stroke volume variation, the waning off of SCVO2 or its interpretation in a different way. We also have looked at the arteriovenous carbon dioxide gradient. We now have understood that a wider gradient is probably representative of a cardiac cause of the hemodynamic instability than a vasodilatory cause of the hemodynamic instability. So this has been also an important paradigm shift in the management or in the recognition of hemodynamic instability. There has always been a debate that a patient who is getting norepinephrine should always get a central line. And for a good part of the last 20 years, that was the norm. If you started vasopressors on somebody, you would make every diligent effort to put in a central line. But of late, this paradigm has shifted, and smaller doses of norepinephrine are now considered safe to be given through a peripheral access for a reasonable length of time before a trained hand can put in a central venous access. So the whole purpose of this paradigm shift, in my understanding, is that it will not delay the administration of a life-saving medication which will defend somebody's mean arterial pressure. So friends, I think as far as hemodynamics are concerned, the changing role of CVP and the changing role of SCVO2 versus the emergence of the tidal volume challenge and the capillary refill time, with understanding of different techniques of identifying fluid overload and acknowledging the role of the right heart in the whole gamut of hemodynamic optimization, the more widespread application of the passive leg raising test, and the application of a simple bedside test called the capillary refill time have been some of the more important paradigms which have shifted or emerged in the field of hemodynamic monitoring in my last 20 years as an intensivist. I'm sure I would have missed some paradigms. Some of you would probably understand and would realize that I have missed a few of these. I've had some messages from some of my friends who have listened to my discussion and said I have missed certain things. Of course, I acknowledge, but it's individual perspective that makes a difference, and I'm happy if some of you can actually tell me personally what paradigms I have missed in hemodynamics. Till then, friends, have a good time and bye bye.